Welcome back to the deep dive. Today, we're jumping into a topic that is both incredibly technical and honestly a little terrifying. Tissue integrity.
It really is. We're pulling from the Wound Care Master module, and what I find interesting is how it forces you to think in two different modes.
Right. It's got the floor for your, immediate clinical actions.
And then exam mode for the deep rationales.
Yeah.
You need both.
Okay, so let's start with the floor, because it kicks off with a total nightmare scenario. Evisceration.
Yeah.
For anyone who doesn't see this daily, that's when a surgical incision opens up and organs are literally coming out. Your first instinct is probably just to panic.
And that's the worst thing you can do. It's a true medical emergency, and your gut instinct is your enemy.
Rule 1.
You never, ever leave the patient.
You call for help for the surgeon?
Immediately. But while you wait, the most important thing is you cannot let that tissue dry out. You have to cover the area.
And the guide is super specific here. It's sterile gauze soaked in sterile saline.
Only sterile saline.
Okay.
And then there's the positioning.
I wanted to ask about that. It says low Fowler's position with the knees slightly bent. That's not just for comfort, is it? It feels mechanical.
Oh, it's pure physics. If they're lying flat, their abdominal muscles are taut, which just pulls that incision apart even more.
But if you bend the knees...
You create slack. You release the tension. It's a tiny adjustment that can save the wound.
And speaking of saving the wound, there's a simple rule here for cleaning that seems so obvious, but is crucial. Least dirty to most dirty.
You start at the incision, the clean part, and you wipe outwards. You don't want to drag skin bacteria back into the wound you're trying to protect.
Right. Don't contaminate your own work.
And the same logic, it applies to prevention. The best wound is the one that never happens in the first place.
We all know about turning patients every 2 hours, but this module highlights a technique I loved the name of, fluting the heels.
That's such a great visual.
Yeah, you put pillows under the calves so the heels are literally just hovering completely off the mattress.
Because the heel has almost no padding. It's just skin over bone. And gravity will win that fight and create a pressure ulcer if you let it.
Which is a perfect transition to exam mode and wound staging. This is where a lot of people get tangled up.
It can be confusing, yeah.
Let's try an analogy. If the skin is a house, stage 1 is just damage to the paint.
I like that. The skin is still intact, but you have redness that doesn't blanch. You press it, and it stays red. The structure's still solid.
Okay, so then stage 2 is we've damaged the siding.
Partial thickness loss. So a shallow ulcer, maybe a blister.
Mm-hmm.
And the key clinical pearl here is what's not there. No slope.
And stage 3, we're going deeper. We're into the insulation.
Full thickness loss. Now you can actually see subcutaneous fat.
So stage 4 is...
We're down to the foundation, the structural beams. You can see muscle, tendon, or even bone.
Which brings up the weird one, unstageable. How can a wound be so bad you can't even stage it?
Well, think about your house analogy. If the foundation is covered in a pile of debris, can't really inspect it, can you?
Okay.
If the base of the wound is covered by SLA, that yellow stringy stuff, or eschar, which is black, dead tissue, you just can't see how deep it goes.
You can't grade what you can't see. Makes sense.
Exactly.
So, once we know the damage, the body has to heal. The module talks about 3 intentions. Primary intention is pretty straightforward. That's a clean surgical cut, all neat and tidy.
Right, edges are brought together. But secondary intention, that's a whole different beast. The wound is left open, and it has to heal from the bottom up.
That's where you see that beefy red tissue, right? Granulation tissue.
Yes, and that's a good sign. It's highly vascular. It means the body is actively rebuilding. But that rebuilding process is metabolically expensive.
Which connects to another point in the source, nutrition. It flags protein as the #1 most critical nutrient.
It's the building block. Without enough protein, your body physically cannot synthesize collagen to form that granulation tissue. All the best wound care in the world won't work if the patient isn't getting protein.
And we can actually see if it's working by looking at the drainage, right? We're looking for something called serosanguineous.
Pale, pink, watery. It's a mix of plasma and a few red blood cells. It's the sign of a healthy, healing wound.
Wow. We've gone from floating heels to the molecular need for protein. It really just shows the level of precision needed in every single step.
It does. And, there's another little note in the source material that I think ties this all together perfectly. It mentions the rule of 15 for hypoglycemia.
For low blood sugar, how does that connect?
Well, the rule is give 15 grams of carbs, wait 15 minutes, then recheck. It's a strict, simple protocol.
Okay.
It's the same principle as the evisceration protocol or floating the heels. In medicine, you can't just guess. The protocol is your safety net. Your gut instinct might tell you to do something else, but you trust the steps.
So whether it's counting minutes or bending knees, you follow the protocol.
That discipline, that's often the difference between a clean scar and a catastrophe.
A great reminder to always respect the checklist. That's all the time we have for this deep dive. Thanks for listening.